Well, what an honor it is to be here today with you this morning. I want to begin with a quote that was passed to me this morning by one of our panel members, because this really embodies what I'm talking about today. Caring is the relationship between the caregivers and patients that regulates the heartbeat of palliative care. Let me say it once more. Caring is the relationship between the caregivers and patients that regulates the heartbeats of palliative care. Just a disclosure, I have no conflict of interest to declare. My work is supported in part by a Canada Research Chair. I really want to acknowledge Madeline Grieg, who is my colleague in the room with me here today, and the Palliative Care Matters team for their incredible assistance in preparing what I'm going to present today. As is so often the case, we get up and present, but there's really a whole lot of people and work that go on behind. So as was mentioned, my topic today is what resources are required to ensure adequate education, training, and mentorship for nurses and healthcare assistants who provide palliative care. I want to begin by taking you on a little bit of a journey, an overview. I think it's important before we actually get to the findings, the research findings, to understand a little bit about the landscape of the family of nursing in Canada, including who they are and some of the key issues that impact upon what we're going to talk about. So when we talk about nurses, we're including nurse practitioners, registered nurses, and licensed practical nurses. Nurse practitioners are educated typically at the graduate level in Canada, beyond the level of a registered nurse. What really distinguishes nurse practitioners in Canada is they have the ability to independently diagnose and prescribe. And then we have a body of registered nurses within Canada. The preparation for registered nurses could be at the diploma level or at the baccalaureate level. We still have roughly half of our nursing workforce that is educated at the diploma level in Canada, although every province and territory, with the exception of Quebec, has already moved toward or is moving toward baccalaureate as entry to practice for this group of nursing care deliverers. And then we have licensed practical nurses, typically have about an 18-month to 2-year preparation. This group is really distinguished by radically increasing scopes of practice in Canada, I would say, over the last decade. And what's really important for this group is that education is regulated at the provincial level. So within each province, these different programs for nursing education are approved, and the primary concern within that approval is safety to the public. The Canadian Association Schools of Nursing accredits entry-level nursing education. They're an important stakeholder in this process, as is the Canadian Nurses Association, who we have here today. They're a policy advocacy body that kind of unites nurses across Canada, and we also have the Canadian Council for Practical Nurse Regulators. So they are very important stakeholders on the Canadian nursing scene. So who are we talking about when we talk about nursing care providers? They have a number of different designations within Canada. They're variously referred to as home health aides, healthcare workers. My monitor left. There we go. Home health workers, residential care aides, personal support workers. What's very important to know about this group of the nursing workforce is that they are unregulated. Although within Canada and within various provinces, there is a movement to having these nursing care providers registered. So a bit different than regulation, but we are moving to have them registered. The length of their education is typically about 7 to 8 months, and what's really important to know is that this group provides the most direct care to palliative patients at home and in residential care. It's very common in the context of my research when I go out and talk to patients and families, when they refer to their nurse, this is often the group that they're referring to. And I think it's very important to note that studies conducted in Canada have indicated that nursing care providers do not feel well prepared for palliative care. Another thing I think that we need to grapple with a little bit before we go into the evidence is the difference between entry-level and specialty education, and I think this is particularly important in relation to the Ipsos poll. So regulated care providers have basic entry-level competencies that all must meet to have their programs approved in Canada. Specialty education typically requires additional preparation, although there is some fluidity in that. But what's really important to note is the boundaries between entry-level and specialty education are not always clear. The requirements for nursing specialty are often influenced by the population. So the more acute the population, the greater the tendency towards specialization. By the workplace context, the more acute and complex that workplace environment is, typically the more move towards specialization. And finally, the workforce availability. For those of you that have been in nursing for any period of time, you know that we go through boom and bust. And so historically, we've gone through periods of workforce oversupply and then shortages, and that very much influences in terms of the boundaries around specialized practice and what's required. Nurses can specialize in palliative care. At this point, and that's through the Canadian Nurses Association. It's important to note that there has not been a lot of uptake on that specialization to date. For example, I think Anne Sutherland-Bold told me last night we have about 380,000 regulated nurses within Canada, and recently I think we have about 1,400 maybe that have adopted this palliative care specialization. And what's important to note is every nurse and nursing care provider must be competent to care for dying patients. Which really brings me to my next topic that I think is really important in terms of laying the groundwork, and that's the difference between palliative care and a palliative approach. Few nurses in Canada work in specialized palliative care. They're just simply not the workplace contexts, but not all patients require specialized palliative care. But what we've learned, ironically, from research is that dying can be problematic in the locations of care where patients are most likely to die, which of course is in our institutional settings, residential care, acute medical settings. I have an article there by Kelly Stadjahar that really sums all this up beautifully, but really it hasn't just been her research, it's been research after research after research that points to this problematic nature. And of course, all patients on a dying trajectory can benefit from a palliative approach. So I just want to briefly show you the population-based model from Palliative Care Australia that I think is really important to look at when you think about preparing any sort of workforce for this population. Basically, they've thought of a palliative population as really coming into 3 different groups based upon the complexity of their needs. So you have one group whose needs will be very well met through primary care, another through intermediate care, and then a final group that truly needs very complex palliative care. And this is very, very important to think about when you think about preparing a nursing workforce to meet the needs of this population. But of course, recognizing that people can transition between these levels as well. So what are we talking about when we're talking about a palliative approach? This language is actually relatively new in the literature, and so one of the things that we embarked on a couple years ago was to do a synthesis of the literature when we say, okay, so when we're using the terminology of a palliative approach, what does the literature say that really defines that concept? And first, it's early support for those on a dying trajectory. We've heard over and over again already how the nature of dying has changed. It is a complex process, it's a much longer process, it starts much earlier. And so we need to be thinking about giving this early support at the same time that we're continuing in some cases to provide acute care. So there's less of a disjuncture between those two. We need to be thinking about it in terms of all life-limiting conditions. We've done some great work for the cancer population in relation to palliative care. That work needs to continue. But we also need to be thinking about all the other populations with chronic life-limiting conditions that require palliative care. And third, we need to think about contexts such as home care, residential care, and acute care, because the requirements of palliative care within each of those different contexts are going to vary. So those are the essential foundations of a palliative approach. And if you want to see more work on that, there's a website there. This is a group that's been funded by the Michael Smith Foundation in British Columbia, who've done a lot of work around a palliative approach, and that website is a really helpful resource for that. Next thing we need to think about is in terms of capacities and responsibilities within the family of nursing. So when you think about preparing them, we need to think about a variety of different factors that will influence that preparation. One is the skill mix. And what we're talking about there is what is the ratio, for example, of regulated to unregulated care providers in that particular workplace context, because that skill mix is going to influence what's required for preparation. You need to think about the patient population, and you can't really just think about this in terms of, for example, the patient population in residential care, because what you may find, and what we found in our research, is in an urban area, in residential care, primarily who will be dying in residential care are the people that are living within residential care. That actually might be quite different in a rural community. In a rural community, you may have palliative beds in residential care that admits young people, for example, for palliative care at the end. So you need to be really thinking in terms of the patient population, the availability and knowledge of other care providers, the health system supports that are available to this workforce, and all of those factors together really determine the types of resources that are required within the family of nursing. Lastly, really thinking in terms of the fundamentals of practice. So when we think about preparing a workforce, we think about knowledge, the theory that is required, we think about the skills that are required, and we think about their abilities, that ability to put it all together and to actually put together that theory and those skills in a knowledgeable way in a practice context. And I'm going to come back to this point over and over again. When we think about abilities, we cannot think simply about individual abilities, that the context within which we place this workforce determines also their ability to enact what they have learned. I'll talk a little bit more about that in a minute. So let's go on to the findings. Unlike some of my colleagues from yesterday, where there has not been a whole lot of research to speak to some of their questions, there actually is a fair bit of research as it relates to preparing the nursing workforce. Just a quick look at the Ipsos Reid results. It was very, very encouraging to see that Canadians place high priority on palliative education, and that a majority indicated agreement with the following: healthcare providers need direct experience in palliative care, certification and mandatory training are important, providers should be screened for compassion and empathy, and workloads are a barrier to high-quality palliative care. And I'm going to come back to each of those points as I discuss the findings. I'm going to talk first of all in terms of the findings in relation to the educational resources, what are out there. When we think about educational resources, we think about them in terms of two things. We think about them in terms of standards and competencies. You might think of these as the roadmap or the blueprint of what should be taught to people. And then we think in terms of curriculum, which is how do we then, that's actually the content of which we go out and then deliver in terms of education. There are a number of really good standards and competencies available to us. The Canadian Hospice Palliative Care Association has done a lot of work in terms of standards of practice and educational resources to support specialty preparation, which is then available through the Canadian Nurses Association. The Canadian Association Schools of Nursing has done some really good work recently. I think this was a 2011, I believe, National Consensus Project, where they designed palliative competencies and educational resources to support integration into entry-level education for registered nurses. So this is a very detailed document. I believe it has 9 competencies with sub-indicators, and so it provides a really nice blueprint for undergraduate nursing education as to if they're going to do this, this means that they're doing it well. The competencies for practical nurses and nursing care providers are a bit more difficult to get at. They tend to be part of national and provincial generic educational competencies. So, for example, if a Ministry of Health has a document that talks about what a nursing care provider in that province should know, they might say something about palliative care within that document. What are some of the challenges around there? The competency statements have varying degrees of specificity in relation to palliative care. So you might have very detailed documents, such as that available through CHPCA, but then again, you're going to have single statements within some documents that simply say, have to be competent in palliative care. So the degree of specificity is all over the map. And there's varying degrees of accountability for competency integration into the curriculum. So if a nursing school is going through accreditation, then you have a document by which you can map their accreditation against what they should be teaching within palliative care. But that certainly doesn't go across the continuum here. There definitely needs to be a little bit more of an accountability mechanism to the integration of the good competencies that do exist. And there's, of course, as I mentioned, been very limited uptake of specialty certification. And unfortunately, we have no national that I could find. I did a bit of digging around, and evidently at one point there was a document started, but I have not been able to get my hands on it, a no national interdisciplinary palliative care competency framework. We did look at one from Ireland that was incredibly well done. It included foundational competencies that all care providers involved in palliative care should have, and then broke it down in terms of each of the different disciplines with subcompetencies, which is very, very useful, because what that does then is provide a roadmap both for interdisciplinary education and for disciplinary specific education. I gotta go back. Lots of curriculum out there, excellent exemplars of curriculum available across Canada. I could name a whole bunch, I won't do that, but really there's lots. I think our problem is that we have little pieces to some extent all over the place, and it's difficult for people to know what's available, and beyond that, to decide what is most appropriate. And so this is particularly in relation to nursing care providers, when you don't have a blueprint against which to map the curriculum that you're looking at to ensure that you've covered all the bases. Beyond that, I think we need to think about a curriculum for a palliative approach. Many curricula will use the term palliative approach to describe their focus. When you actually drill down a bit more, you'll see that there are very few that actually address the three criteria of A, early intervention. So they need to include things such as advanced care planning, discussions about goals of care, really trying to think about an upstream approach. 2, adaptation to a variety of chronic life-limiting conditions, and this is really complex. So when you think about a nurse that's caring for a heart failure patient at end of life, this nurse needs to have knowledge both about palliative care and still knowledge about acute heart failure intervention, right? So they need the basic terminology about what's going on, and so there needs to be that adaptation of both in there, and then of course adaptation to contexts of care. And so we do need to do some work around thinking about competency frameworks in terms of a palliative approach as well. And now to the meat. What about the findings about educational effectiveness? So when we say at the end of the day we're delivering all this curriculum, what do we know about what it does at the end of the day? We did a palliative nursing education review a couple years ago. We managed to find 58 studies specific to nursing that were published within the last decade. There was wide variability in duration and content of that education. The duration went anywhere from 1 hour to 130 hours, from a single session to education that had implemented over 4 years. There were positive outcomes reported in 86% of those studies, but that of course must be viewed cautiously because there is publication bias. So very few of us are going to produce a paper where we say, hey, look, we did all this education and none of it worked. And so what you're actually going to see in the literature is that type of publication bias, so you need to be a bit cautious about that. But what we also did in this paper is we calculated effect sizes across the studies, and so that's where you actually do a mathematical calculation asking the question of, how big was the effect on the different outcomes that these studies mapped? And what we found is that there was a large effect on nurses' stress. No surprise, right? If you want to make a nurse stressed, you make he or she go out and look after a population for whom they do not feel competent to look after. So large effect on nurses' stress, moderate effect on communication, attitudes, knowledge, and confidence, small effect on anxiety, perceptions, work environment, and changes in practice. These studies unfortunately examined primarily individual level outcomes, and what I mean by that is, at the end of the day, this individual took this education and this is what they reported in terms of their own confidence and knowledge. There was few outcomes that looked at system level change and, more importantly, change at the patient and the family level. And so, and many of these studies, as happens in most educational research, very strong methodological limitations. So we're just a little bit cautious. I think it's a really good start, but more work needs to be done. We did find one review specific to rural nurses, and boy, if I can make one really key point, is that we need to think about this workforce differently. I've done a lot of studies with rural nurses, and you know how they characterize their work? They say, "We're it." And that really is the case. In many cases, they're working without any sort of multidisciplinary backup as it relates to palliative care, any sort of palliative care structures or supports within their community, and worse, they may be working with colleagues who have no knowledge of palliative care because they may indeed have been educated in another country. And you layer on that the incredible stress of looking after family and friends at end of life and not being able to mobilize the support that they require. It leads to a huge amount of moral distress. And so when we think about preparing the nursing workforce, we need to think uniquely around the context of rural nursing. I won't go through all of the details here on this slide, but really we can't draw a lot of conclusions. There were very few studies in this review, and they had a very variable focus. There were some interesting select findings from various studies, and one is that individualized learning led to knowledge and practice gains. So this is where a nurse can sit down and not have to take the whole package of learning, but to be able to identify, these are my weak areas and here's where I want to engage with the learning. We just completed a study with nurses in British Columbia around their confidence in a palliative approach, and it was very, very clear from that survey that there were areas where nurses actually felt quite competent and areas where they felt way less competent. And so you can individualize that. Mentorship and support are critical real-world learning, which of course doesn't happen for a lot of nurses, because oftentimes people do not feel competent until they've actually cared for a patient who is actively dying. And many, many nurses, I would hazard the majority of nurses, will get through their education without actually caring for a patient who dies within their care. So that is a bit of a challenge from a nursing competence perspective. And then there was a very unique study that educated home care nurses to provide informal education to general practitioners. And this is the one thing we don't talk about a whole lot, but some of these community care nurses are actually the experts in palliative care in their particular constellation of healthcare relationships. And so they actually have to do a lot of education of physicians in their context. And so this was a very unique study because it actually recognized that and helped nurses to do that diplomatically. And so really nice piece of work. A couple of articles, reviews focused on undergraduate preparation. These were both published in 2014. You'll be interested to know that the time devoted to palliative care ranged anywhere from 2 to 50 hours. There was a heavy emphasis on experiential learning, which is a good thing, but unfortunately it's very, very difficult to evaluate experiential learning. You send somebody out to do an active kind of learning, so you end up in these studies with a lot of mixed findings, and that's indeed what happened. But what they all agreed on, it's important to pay attention to the level, characteristics, and experiences with death of the learning, particularly in undergraduate preparation. Some intriguing work being done within simulation, because of course if you can't give people access to the population you want them to feel competent in, we need to think about simulation. This research is in its very early stages, but it does hold some promise in terms of increasing the comfort, attitude, knowledge, and confidence of the learner, but very important to support students' psychological safety through that process. This is actually a very steep learning curve for students, and something that they may not have thought about too much, interestingly enough, when they come into nursing. Educating nursing care providers, we actually were only able to find one published review that was very specific to long-term care, but you know what? This really holds a promise for huge returns with little investment, because this group feels so unprepared at times for palliative care that you can do short interventions with them and see maximum gains. And so studies located for our review suggested gains such as better understanding of the roles of the healthcare team, enhanced confidence in communicating with the team, more responsibility for identifying those on a dying trajectory, enhanced abilities to interact with patients and families, increased confidence and to their contributions to care. This is critical. This has been a largely invisible workforce. They need to know and be acknowledged for how much they contribute to the care of this population, and greater familiarity with palliative practice support tools. We did find a couple of studies where they actually educated nursing care providers with nurses. It was enormously successful, but there were some findings from those studies. If you're going to embark on doing that, it's very important to pay attention to the baseline knowledge and orient nursing care providers in particular to unfamiliar learning strategies. Interdisciplinary learning largely is done through case-based. Nursing care providers actually may have had no experience with case-based learning. So they come into this learning environment feeling quite disoriented in that learning style. So it's important to help them with that, to strategize a comfortable learning environment so that they feel like they're entering as part of the team when traditionally they have not been considered part of the team, and use strategies to build their confidence. We learned a little bit yesterday from one of the speakers about the unique knowledges that each person brings to this. They bring very unique knowledge by being the closest to the patient. And so it's a matter in education of learning to draw upon that such that they truly feel part of that collaboration. Most important point, I believe, is this idea of knowledge translation at the end of the day. The workplace context, as you saw in the Ipsos Reid poll, is critical for knowledge uptake and adaptation. We know now you cannot just give people knowledge. That knowledge needs to be taken, it needs to be adapted, it needs to be refined in an iterative process, and practice support tools are necessary. And I would even say that if you go out and educate a workforce about high-quality palliative care, and then you send them into a context where they cannot enact that, you're actually contributing to moral distress. And so we need to really think about barriers that have been cited over and over and over again in studies about barriers to palliative care for the workforce, and that's workload, it's interpersonal tensions, it's all of the lack of communication mechanisms that have been taken away as the realities of economics have hit healthcare, and poor support in coping with death over time. This is particularly the story of nursing care providers. They work in residential care where they form very strong relationships with residents over time, family-like relationships, and then these residents pass away. And they pass away over and over and over again, and we pay very little attention, I think, to ensuring the well-being of these individuals within the workforce over time. Implications, just very summarizing what I have mentioned in this talk, national standardized interdisciplinary palliative competencies would facilitate the development and evaluation of education. And we really need to know where everything is in this country. There are pockets of excellence all over, but we really need to put, because this curriculum is being created in different places. You know, I did mention, you know what, I missed a slide, and I need to go back for a minute here because I did not mention the two curriculum that have been strongly influential in North America. My button must have gone 1, 2, but one was the LNAC. So in our findings, the LNAC has been probably the most well-researched and well-funded nursing initiative in North America. It was funded by the Robert Wood Johnson Foundation, started in 2000, I believe, and that capacity building project is now international, and I believe they have educated over 20,000 nurses and healthcare providers. We also here in Canada have Palliative, an excellent resource, interdisciplinary, that focuses both on discipline-specific and interdisciplinary, has had huge reach and has very strong curriculum. So I'm sorry, I'm not quite sure how that happened in my slides. But important, we do have excellent resources. Evidence reports on short-term gains in individual knowledge, competence, and attitudes. We know less about whether these gains are sustained or about patient and system-level outcomes. The message is, if we're going to do capacity building, we absolutely need to put in place strong evaluative mechanisms that look at the outcomes that we're most interested in. Collaborative education is most effective when combined with discipline-specific education. Education in a palliative approach needs to be provided alongside specialized palliative care education. Simulation, online learning, informal workplace learning, and apprenticeships hold promise for extending the reach, but we need to think about innovation and creativity, and there hasn't been a whole lot of research done around that. Most important, conducive practice context are a critical resource for enactment and refinement of palliative care knowledge. Thank you.
Thank you very much. You've given our panel and the audience a tremendous amount to think about. As usual, we'll lead off the questions with the panel. Over to you, Don.
Thank you, Fred, and good morning, everybody. The panel has taken in, I think, and thank you very much for the presentation. A very, as Fred said, very engrossing presentation. To lead off the questioning on this topic, Penny Erickson. Penny.
My voice here. That was a wonderful presentation. I thoroughly benefited from hearing all of your comments. One of the things that I'd like you to talk to us more about, if possible, is the assessment of the compassion and caring and how that is attempted in educational programs. How do they assess it? How do they encourage it? We talk about it almost like it's easy.
Yeah, such a good question. It's not easy at all, isn't it? This was our breakfast conversation this morning. Most nursing education programs now will have a heavy emphasis on relational practice. So they'll have a number of courses weaved throughout the curriculum that are specifically designed to produce compassionate nurses across diverse persons. They're meant to increase their sensitivity to the things that they don't think about, to promote reflective practice. So I would say it's fairly well embedded. The thing that I'm concerned a little bit about, and I also have to actually put in a plug here for Shane Sinclair's work at the University of Calgary, because he's doing some amazing empirical work around compassion, including a compassion model, what it is we need to be thinking about in terms of relational practice if we think we're building compassion in healthcare providers. But I think that there were some really good lessons to be learned from the Francis report. And when that, for those of you that don't know, this was a report that came out as a result of some real failures of compassion in institutional settings. And, when the Francis report came out, some of the early indications were, well, we need to educate nurses about compassion, and we need to put into place quality frameworks such that we enforce compassion. And, that's a good beginning point, but unfortunately, one of the things we often do in failures of all kinds of things is we immediately go to education. And there's been a really interesting body of literature that's come out since the Francis report that talks about all of the other things contextually that contribute to failures of compassion. And so these are as things like, what do you do with people what happens to people when you put them in contexts that are incredibly time pressured with multiple stimuli and then expect them to continue on and be compassionate and attentive individuals? You know, there's all kinds of other factors that come to play. And so I think, you know, we certainly need to continue on in terms of thinking very carefully about educating nurses and assessing them in terms of compassionate responses. I think we also need to pay attention to some of the research that's coming out about how our increasingly technological and time-pressured workplace environments are influencing us as people.
Thank you. I have one more question I'd like to follow up on with that, because this is one of my concerns with the inability of people to be compassionate in the workplace, and that is the organization of our healthcare based on a financial basis, not an outcomes basis. It seems that nursing care has been reduced to tasks that can be measured quickly and provide the cure rather than the care of the patient. And it distresses me because it affects the effect of the nursing care, and it diminishes the benefit that the patient has from having had a nurse at the bedside.
Yes.
And we haven't, to me, we just haven't worked with that problem enough to provide the patients with what they need and the nurses with the ability to do what they can do.
I so agree. I so agree. And I always hesitate to go here because you hate to always think about individualized solutions to what are often systemic problems. But, you know, in our research, I really have seen some nurses who are able to do really good work, even amidst the complexity that you're talking about. And I had the privilege of shadowing a rural nurse one day who was working in a hospital where she was looking after both acute medical patients and palliative patients who were in separate rooms. And I watched her go about her very, very busy day. And then as she would enter the door of the room of that palliative patient, she would stop for a moment, she would take a breath, she would gather herself, and then she would walk in and be fully present for that person in that room. And it was a remarkable exemplar of something that I think we can help nurses to realize. But it was actually at great cost to her when she talked about that process and having to feel guilty about everything that was going on that medical unit while she was taking time to be present in that room. And the real strategies it took for her as a person to do that well over time. I do think we can teach some of those things. I don't think it's a solution to some of the more systemic problems that you're talking about in terms of nursing workplaces.
Yeah, thank you.
Thank you very much, Dr. Pesut. And I was wondering, how could we bring some sort of a balance within the system that there is tremendous amount of pressure apparently on the nurses, that so they can also be able to focus on their own self-care as well as become more productive and helpful and caring, toward the patients. But also maybe, for example, if the nurses are working, let's say 10, 12 hours a day or whatever it is, maybe somehow we can manage, to bring the time, to a lesser amount so they can focus on not only enhancing their own knowledge and experience, but also transfer this to other, nurses or other caregivers. Thank you.
Yeah, it's so true. We are, I think, increasingly in nursing programs focusing on solid strategies for self-care. And we get student feedback that's actually very helpful. It's a little bit harder for them to hold on to that, I think, when they enter the workplace. And I think what we need to be looking at is there are exemplars of workplaces that do this magnificently. Where they really have strong leadership. And it's actually often leadership that's very close to nurses. It stays very close to the bedside. Men and women who are in leadership positions who focus very specifically on helping their staff care for themselves. I think we need to probably learn from these workplace environments and help them to get rolled out more broadly. But it is a very complicated issue. Thank you for that question.
Thank you for your great presentation. And it all sounds great, all that education. And I'm familiar with that comment that you said, we're it. So I have great concern for First Nations nurses that are working in remote and especially in the fly-in communities, where they have no professional palliative care team, where their team might be an elder and a healthcare worker and a family member. And maybe, if they're lucky, another nurse in the community, but in some cases that's rare. And I'm interested in the outcomes that you talked about and how effective all this education is going to be, and is it going to be effective? And so I have concern for the First Nations nurses, and how will they be able to access this kind of education when they are overburdened, overworked, and they cannot leave the community because they're the only nurse in the community. And they really need to have this education to help them do better care and, to be better present for their dying people. And I know, in my experience, I know the nurses have been very dedicated and very committed, and they go beyond what is required of them. So, in other words, I think they are very compassionate and very caring. So I'm just worried about this education part of their, that would be available for them. How will they access this, and who will cover the cost of it, especially if they cannot leave the community and be away for a great length of time.
Yeah, it's key issues, aren't they? In my experience, what often happens in rural communities is you end up having some real palliative champions. And so these are the people that, go out and get the additional education and then come back and often informally help their colleagues to understand how to do this well. But I do think we need to be very determined in how we support these nurses. I think we need to make some initial investments in face-to-face learning. We do know from the literature that they do prefer face-to-face learning, and that there is certainly a role for distance education, but that is usually probably after that initial education where they've had a chance to get into an interdisciplinary environment and do some real good face-to-face learning. And then I think there are innovative strategies that we can implement that use a train-the-trainer type approach so that these can be champions as they go back to their communities to help build capacity. I think that's very important. And then, as was talked about so much yesterday, we really need to think in terms of getting into these communities and understanding how should this play out in this community. Because what I have found in my research over and over again is that there are a group of champions with actual enormous capacity to do high-quality palliative care. But what often happens is their best efforts are interrupted in multiple ways. And often what this is urban-generated policies that are very, very well intended and are meant to solve a solution, but actually end up having unintended effects within rural healthcare providers. And so we need to get into these communities, we need to understand what the effects of our policies are, and very strategically decide how can we best support these champions that are existing within their communities in new and unique and creative ways.
Other panel questions? Serena, and then Ken.
What a fantastic presentation, thank you. I'm really delighted that you hit and really focused on the systemic levels of issues that we're up against, as well as highlighting a bit of the hierarchy that's internally there for a lot of organizations. What I find, and I think it's fascinating, is that we kind of get into this place of good nurse, bad nurse, which individualizes the problem. So I'm so delighted that you hit on that, because what I've seen so much is that we're stripping away the authenticity of what brought people into these roles. We encourage them to go to EAP, when they're not handling things well, which I disagree with that languaging. I really think what you're talking about too really enhances that critical self-reflection within teams and that peer-led driven support. And also to really start to look at that interdisciplinary approach and how we can approach this whole disenfranchised grief. And what I'm starting to kind of recognize and believe that we need to start creating better grief-friendly workplaces, because that's what keeps the authenticity that I see in the wonderful nurses that I have the opportunity to work with all the time. So I just really want to commend you. Do you see a place for disenfranchised grief in this?
Yeah, absolutely. Thank you so much for your comment. Yeah, because it actually just goes underground, doesn't it? And it creates a whole lot of stress. And, you know, in the studies that we've done with healthcare providers, when they talked about the distress that they experienced, for example, from multiple deaths, it did not take a lot to put in place things in the workplace environment that would acknowledge their grief in a very visible way. We heard some lovely rituals that some of them had started within their particular residential care facilities that really helped them to deal with the grief collectively and thus heal their individual souls as they did that together. So yes, it's not a big investment in terms of what's required, but huge payback in terms of, yeah, thank you for that comment.
Ken.
Thanks again for another very, very useful presentation. So my question gets back to the competencies that you were talking about and foundational competencies, and I can't help but think about the combined aging and diversity of the Canadian population, and that people approaching death will approach it with different cultural understandings of what constitutes death, the meaning of death, what the experience of death is, and that if we're to have culturally congruent palliative care, then cultural competency must be essential, and whoever's giving the next presentation is going to confront this question as well. That cultural training is got to be core to a consideration of foundational competencies. And I think back to that classic volume that came out a few years ago, The Spirit Catches You and You Fall Down, which revealed the vast divide between the Hmong population in the United States and clinical practitioners, whether they were nurses or doctors, and the struggle that kind of brought about, and the renewal of the treatment of culture in medical education. And I don't know the first thing about nursing education, but I looked at your list of references and there wasn't one that touched upon culture unless it was buried within each of the references that you cited. So I wonder if you could speak to the question of cultural competency in nursing.
Such a good one. And of course, that would be embedded within the palliative competencies. It would be, you know, it's quite assumed actually within nursing education. Assumed, I shouldn't say that. But we do focus very hard on a relational model where inquiry is at the foundation. And so nurses need to be curious about what it is that is at the identity of that particular person and how it manifests within healthcare. So whether we're thinking about diversity along the lines of ethnicity, spirituality, religion, it's this idea that the nurse will be curious and will have the courage to engage around things that they may not be familiar with, and will do that in a way that acknowledges that foundational importance within healthcare. So yes, it needs to be certainly profiled within all of the palliative care competencies. It also needs to be at the foundation of what we do within basic preparation. Thank you.
Next question from Mark.
I just wanted to follow up on that
you
quickly,
okay,
if I
go.
could. Curiosity is great, but that doesn't produce a competency. That skill comes from education, and especially in the area of cultural competency, you know, like an anthropology course that teaches you how to actually process and analyze what it is that you're observing becomes remarkably important to developing those kinds of skills. And to realizing that even though you might be in a geographical location that does not have the kind of diversity that a major urban center in Canada might have, that it's a skill that you can carry if you happen to move in your profession. So it's just, you know,
Yes,
It's
yeah,
not
really.
simply something that happens through curiosity. It's
Oh.
something that has to be core to the education system.
Yeah, such a good point. And I think what we're doing in nursing right now is we're really trying to grapple with the balance between stereotyping and a type of approach that really kind of solidifies people within one particular way of thinking about them, and moving and balancing that with a curiosity such that we realize that people take on multiple and complex identities depending upon all different types of factors. So in nursing, we're really grappling with how to do that well. How do we teach people basic concepts around culture and diversity, while yet also encouraging a spirit of curiosity such that they don't stereotype people within particular ideas. So we're working hard to try and find that balance, and I think we do it to varying degrees of success. So thank you.
Thank you for your presentation. Very pleased to see the discussion around competencies and learning outcomes. You said a little bit about knowledge translation that had taken place in the workplace after they're done education. Can you say a little bit more about assessment of outcomes during the education process?
Assessment of outcomes during so the assessment in terms of the knowledge translation activities?
No, before you get to the knowledge translation, how have you identified that these competencies have been met before they're sent or they're certified?
Oh, yeah. Okay, so that's, and when I talked about some of the types of methodological weaknesses that are in these studies, what it's very characteristic to see across them is you'll ask nurses, how well prepared they feel now along a variety of domains. And so when we did the survey in British Columbia, they had a whole variety of domains, and they had to rate themselves on a scale of 1 to 5 on their self-perceived competence in relation to these domains. A number of studies will actually give them kind of tests of basic knowledge that isn't just my self-perceived competency, but do you actually have the knowledge required? And so those are kind of the most common indicators that we would use. But as somebody can have great self-perceived competence and then can get into the workplace environment, and it was really, and have that all kind of shaken. Indeed, it was very interesting because one of our studies showed that when we did it at multiple points, where initial education, before, after, and then into the workplace, their actual self-perceived competence was quite shaken, because now they were interacting with the realities of the practice environment. And so those are the types of measurements that we've largely relied upon in terms of assessing how people feel. Some of the sort of intriguing knowledge translation projects that we've done that have been a little bit differently, we have actually, and you can look at the iPanel website that I showed you in terms of seeing the results of these studies. But what we would do then is introduce nurses to the concept of a palliative approach and say, this is an important concept for your workplace environment. How would you take up this knowledge and adapt it into your context? And then we'd study them for the next 12 to 18 months and see what they did. And it was actually very, very creative things that nurses designed themselves in terms of enacting this knowledge and embedding it into their workplace environments. So it's kind of like you need both and. So, people need basic knowledge and competencies. We also need to be working at the KT approach such that it really gets embedded into the workplace.
Serena again?
I just wanted to clarify kind of, and how are we finding the leadership and the education that have both the research base and the translatable, that's sometimes the transferable skills of having people delivering education that actually have the palliative care knowledge and skills under their belt.
Isn't that interesting? We had a little talk about that over breakfast. So there was a study done quite some time ago, both in the United States and in Canada, that suggested that faculty probably felt less than well prepared in basic undergraduate nursing education in terms of delivering this content, which of course, is then going to result in people not. My understanding is that we have a survey going on right now in the country that we'll have the findings of fairly soon, in terms of looking at that again. That's pretty old evidence, but it can certainly have an impact if you don't have well-prepared faculty that are confident in this knowledge themselves.
Thank you.
Further question? Yes, Penny.
This is something we usually don't talk about, but what have the discussions been about a targeted fund of money to help with the education for more nurses in palliative care, given the paucity of this population and the explosion of those in need? Have there been discussions at the federal level to have targeted funding for this educational need?
Yeah, no, there are a number of experts also within the audience who would probably actually even be able to speak to this better than I, and I'm hoping that they'll contribute that at some point. But just from my own provincial context, I do know that we have the BC Centre for Palliative Care that is expending resources into this right now. I know a number of our health regions are investing in education right now, but I'm not sure that anybody, and correct me if I'm wrong, those of you who are sitting in the audience, has the pulse probably on what's happening within every jurisdiction across Canada in terms of capacity building. And that maybe we need to find out a little bit more about that.